Hello everybody, and welcome to Dr. Sam's anatomy classes. Now here I'm going to tell you about this human anatomy question paper 2 of RUHS, Rajasthan University of Health Sciences. This question paper was meant for this MBBS students of 2020 batch. But this exam was conducted on January 2022, which is actually 13th of January 2022. This is the main examination, and as you know, it was of 3 hours, 100 marks question paper. Section A was containing again 6 fill in the blanks, 4 MCQs, then a clinical question of 15 marks, then short notes 10 marks, explain briefly. Section B, all this is like subjective portion, and I'll be telling you briefly about all these questions later on. First, let's begin with this section A, fill in the blanks. The first question is, trachea bifurcates at dash vertebral level. So the best answer here will be T4, T5 junction. And that is the level of the sternal angle, the manubrosternal joint in front. But if this question would have been in the form of an MCQ, and if you had options of T4, T5 both, then I would suggest to mark T5, which is supposedly a little better answer. You know, this level of bifurcation of trachea is not fixed. It descends down a little while deep inhalation. It even moves a little above while lying down supine, and in various other activities, various other movements of the body. So actually speaking, the bifurcation level lies between T4 and T5. So T4, T5, if separately asked, both are correct. But to be more on the safer side, you can mark as T5. Now this is how trachea bifurcates. If you see the midline, trachea is slightly deviated towards the right side in the superior mediastinum. And you also know that the right principal bronchus is shorter and wider, and it's more in the vertical alignment of the trachea, while the left principal bronchus is more deviated, more inclined towards the left side, making more of angulation here, and it is longer and narrower as well. So this is left principal bronchus, this is right principal bronchus, and this is the trachea. Now this is the level of sternal angle in front. This is how manubrium overlies trachea in the superior mediastinum anteriorly, and here it will be the body of sternum. You know, this manubrosternal joint, which is also called sternal angle or angle of Lewis, this passes between T4 and T5 vertebral levels, and this thing is called carina, the terminal bifurcation of trachea. So you must have read it many times regarding the structures met in the transverse section, the transverse plane passing to the sternal angle. They'll mention that trachea bifurcates at this level, or the carina is found at this level. This will be the position of T4 vertebra, and this is T5. There are 13 structural changes that are happening at this level of sternal angle. I have mentioned them in some of my videos. So the best answer that you can give for the vertebral level of terminal bifurcation of trachea, the answer will be T4, T5. This is the best answer. The next best answer will be T5, and even T4 is not wrong. Next question is, joint present between manubrium and body of sternum is. Look, we were just talking about this joint before. So the answer here will be secondary cartilaginous joint. What are the other examples of secondary cartilaginous joints? Let me brief you about this. First of all, look at the structure. It's a joint between two bones. So let's say these are the two meeting edges of the bone, and here these bones are lined by hyaline cartilage. That's the articular cartilage. Then interpressed between the two articular surfaces, there is a disc placed here. This disc is made up of fibrocartilage. This green color one is hyaline cartilage. These are the two bones. So that's the structure of a secondary cartilaginous joint. And because of the presence of a fibrocartilaginous disc in between the two edges of the bone, this joint is slightly movable. Now the characteristic features of this joint is, one thing is that this is a permanent joint. Unlike the primary cartilaginous joints, which are temporary joints, they are only present until there is skeletal maturity. Once there is synchondrosis happening, the joint undergoes fusion in case of primary cartilaginous joint. But this one persists throughout life. And that's why they provide slight movability. There's slight movement which is permissible. And this is present in the median plane of the body. So this will help you remember the examples also. You don't have to think on the right and the left side. Simply in the median plane. And this will fetch out another characteristic feature of this joint. From the third point, you can guess the fourth point. What will it be? That these joints are unpaired. Now what is more important for you is the examples. One, as it's in the question, mandibulosternal joint, then pubic symphysis, then intervertebral joint. But the answer is not complete. Between two successive vertebrae, there are three joints. So just writing intervertebral joint is not a complete answer. It should be intervertebral joint between the body of vertebrae, or between the centrum of the vertebrae, because there are posterior articular facets attached to the lamina, or posteriorly the neural arch of a vertebrae. So there are projections, articular projections facing above and below, and they articulate with the successive vertebrae above and below. And those are paired joints, so they are plain synovial joint, and those are called zygapophyseal joints. So remember this important point next time. Next question is, nutrient artery to tibia is derived from. Answer will be posterior tibial artery. This I have described in detail for all the long bones. If you see my lecture on long bones, you will find it in detail. Let me revise it for you here, just to tell you the nutrient artery of all the long bones. So you know there are 7 long bones in the human body on one side, that makes 14 long bones overall in human body. But I've included scapula for a reason, I'll tell you soon. Without taking much time, you just need to know the answer for all of this. Clavicle, the blood supply is by nutrient branch of suprascapular artery. Now suprascapular artery is a branch of thyrocervical trunk, which is a branch of first part of subclavian artery. Now you've got to know now why I've mentioned scapula. Yes, if you people have guessed it, then it's so good. So scapula also receives the nutrient artery from the same artery. Both clavicle and scapula are provided nutritional arteries from suprascapular artery. Humerus, it's a nutrient branch of, it's a direct branch of brachial artery. Radius, it's a nutritional branch of anterior interosseous artery. Now, anterior interosseous artery is a branch of common interosseous artery, and common interosseous artery is the largest branch of ulnar artery. in the forearm. Now, Allah, so easy for you. Nutrient artery to ulna is same as that for radius. Means both radius and ulna are being provided nutritional branches through the anterior interosseous artery, which is a deep artery running over to the interosseous membrane in the front of the forearm, femur. Now, nutritional branch of, you must be guessing it. If you compare the homology, you must have guessed humerus, femur, right? So guess it fast. If you're guessing it femoral artery, then your funda is correct, but your answer is wrong. So because like thigh is a very bulkier organ compared to the arm, so there's a deeper lying artery reaching in approximation to femur, and that is profunda femoral artery. Nutrient branch of profunda femoral artery gives nutritional branch to femur, but to be more precise, remember that profunda femoral artery gives out 1, 2, 3 and 4 perforators that wind around from medial side, perforating all the muscles attached in the linea aspera. And ultimately all these 4 perforators bury themselves into the substance of the bulkiest muscle of the thigh, that is vastus lateralis. So during its course, it will give its nutritional branch to femur through its second perforator. Remember this. The first perforator has also a significance that participates in the cruciate anastomosis on the back of thigh. Now tibia. Compare the homology. Radius is homologous to tibia, so the blood supply to tibia will be from nutritional branch of posterior tibial artery. You know, the front of forearm is a bulkier compartment, right? So that's why anterior interosseous is a major continuation of common interosseous artery, and posterior interosseous artery in the back of forearm is a minor terminal branch of common interosseous in the forearm. So that's why anterior interosseous provides blood to both the bones, radius and ulna. Now in the leg, if you compare the leg, front of forearm is homologous to back of leg, and back of leg is bulkier compared to the front of leg. So the terminal branches of popliteal artery are anterior and posterior tibial arteries. But posterior tibial artery is the major branch, or you can say it's a continuation of popliteal artery in the back of leg, while anterior tibial artery is a minor terminal branch. So now this is same as homologous to the forearm. So posterior tibial artery will provide nutritional branch to tibia, and this was the question as a fill in the blank in your exam. What will be the blood supply to fibula? Nutritional branch from which artery? Now again compare the homology and guess the answer. If you're guessing it to be posterior tibial artery, then your funda is correct, but the answer is wrong, because back of leg and front of forearm has some difference. The difference is that the back of leg is even much more bulkier. So this artery, posterior tibial artery, is not sufficient enough to provide blood to the entire compartment that is back of leg. So instead it gives its lateral branch, or you can say the collateral branch of posterior tibial artery in the back of leg is the peroneal artery, the fibular artery. So peroneal artery is the largest and the longest branch of posterior tibial artery in the leg, and this artery will provide blood to fibula. So blood supply to fibula is by a nutritional branch from fibular artery or peroneal artery. The next question is, remnants of paramesonephric duct in male are dash and dash. You know, paramesonephric duct is a genital duct which is meant to form the uterine tubes, uterus and the upper part of vagina in females. So when this is not being happening in males, that means this will degenerate in males, but its terminal portions persist in a rudimentary form. The upper end, the cranial end, and the caudal end at the lower end. So at the upper end, it persists in the form of appendix of testis. And at the lower end, it will persist in the form of prostatic utricle. Should I help you in understanding this? Okay. This is the body wall. This is the vertebrae. This is the dorsal aorta. And here it is this parietal peritoneum. This parietal peritoneum covers the intermediate mesoderm. The intermediate mesoderm is cord-like mesoderm being developed here on the two sides of the body wall posteriorly. It's like this vertically aligned, cranial to caudal, and it is all covered by peritoneum like this, peritoneal covered structure. This is the intermediate mesoderm, the blue colored structure, which we call as nephrogenic cord. Now this nephrogenic cord develops into three tubes. Most medially it thickens to form the genital ridge in the lumbar region, and that forms the future gonads. Then there develops another duct, and that is called mesonephric duct. Now this is going to form the duct system of the ejaculatory pathway in males, like vasa efferentia, epididymis, vas deferens, seminal vesicles, ejaculatory ducts, and even the prostatic portion of this prostatic urethra, posterior portion. And this also helps to develop the excretory pathway, conductive pathway of the urine, right from the collecting ducts of the kidneys. Collecting ducts, minor calyces, major calyces, renal pelvis, ureters, and the posterior portion of the urinary bladder covering the trigone, and even the portion posteriorly contributing to the prostatic urethra. So that's how that you can understand now mesonephric duct, the derivatives of mesonephric duct is present both in males and females. The excretory pathway in both male and female, the ejaculatory pathway only in males. And this mesonephric duct in females will persist in the form of epiphoron, paraoophoron, Gardner's duct, right? That's within the broad ligament on the sides of this uterus. Okay. Now lateral to that is another duct that develops here. Now this duct is paramesonephric duct. Now para, as you know, para means adjacent. So because it's adjacent or aligned lateral to the mesonephric duct, it's called paramesonephric duct, and it's going to form the reproductive system in the females, including fallopian tubes, uterus, and the upper portion of the vagina. This will persist in males only at the cranial and the caudal end. In the cranial end in the form of appendix of testis, and at the caudal end in the form of prostatic utricle. By the way, there's one more thing that I want to tell you, that this nephrogenic cord has been divided into three portions like this. The most cranial portion of this nephrogenic cord is called pronephros. The middle portion is called mesonephros. And the lower portion, terminal portion down towards the pelvis, this is called metanephros. Now look here, I'm going to zoom out this thing here. On the two sides you find is the developing gonads, right? These are being developed from the medial edge of this mesonephros in the lumbar region by the formation of this genital ridge. Then lateral to that was mesonephric duct, which were descending down like this from both the sides. And with the contribution of the mesonephros actually, I'll tell you, this pronephros, mesonephros, metanephros, this is a mesodermal tissue which will help to form the nephrons in the kidney. And if in the region of mesonephros, they later on they do not form the nephrons, so they rather form the vasa efferentia in males, which you can see this is going to form vasa efferentia. In case if they ask what is developed from mesonephros, this is mesonephros, and this thing will be happening both the sides. This is how this is going to descend down like this. And while it descends down, it sends out ureteric buds on the two sides. Now this ureteric bud elongates to form the ureters, renal pelvis, major minor calyces and the collecting tubules. Now this mesonephric duct, when it descends down, it will join this primitive urogenital sinus, which is going to form the future bladder and portion of the prostatic urethra as well. So this mesonephric duct will also contribute to the formation of this trigone, covering of the trigone, as well as the posterior portion of this prostatic urethra. All this is being formed by this mesonephric ducts. Now later to that, as I was telling, there was paramesonephric ducts which were being formed. Now this paramesonephric duct, it descends down and it winds medially anterior to this paramesonephric duct and will descend down like this and will reach to the primitive urogenital sinus like this. The two ducts like this. And then when they meet in the midline, they actually fuse posterior. Actually, it's going like down like this behind to the developing bladder and will fuse here like this. Got it now? So what is it going to develop in females later on? First of all, let me mark it. This is paramesonephric ducts, and this will form the fallopian tubes, uterus and upper vagina. In males, what will happen? Consider this to be the testis being formed. Only this much portion of this paramesonephric duct will persist. Rest of it will degenerate. And when it will reach here, the urinary bladder and the prostatic urethra, here as you know, the two mesonephric ducts join and they form a single portion here that's forming future uterus in an upper portion of vagina in females, and in males it will be present as this utricle in the prostatic urethra over to this verumontanum. This is called prostatic utricle, and this is appendix of testis. Remember one other important point about this appendix of testis, that it is also called, this can be an MCQ in future, it is also called Hydatid of Morgagni. This is also called Hydatid of Morgagni. Prostatic utricle is homologous to uterus and vagina in males. Now again, this can be a very silly type of question when they ask like prostatic utricle is homologous to uterus or vagina in males. Then you should go for vagina because it's the terminal portion of paramesonephric duct. So remember that appendix of testis is also called Hydatid of Morgagni. Next question here is the largest sesamoid bone in the body is. So the answer is very easy, as you all know that it is patella. Okay, now let me summarize you with the sesamoid bones present in the human body. They are very oftenly asked in exams. So first one is patella. It is the largest sesamoid bone. This has been asked you in your exam. It can be asked like it's a sesamoid bone. Sesamoid bones are the bone formed within the tendon of the muscles, where there are chances of weathering and tearing, where the hinge being formed, wherever a joint in between. This is for a support for better flexion, contraction of the muscles to bring about more of work with less of effort. So, patella is formed within the tendon of quadriceps femoris. Next is pisiform. Now, pisiform is formed within the tendon of which muscle? Flexor carpi ulnaris. Third one is fibula. Now, where is fibula found? Fibula is found within the tendon of the lateral head of gastrocnemius. Now, there are few more sesamoid bones which have not been actually given name. They are unnamed sesamoid bones, but they're asked or they're important to know. So, one sesamoid bone is also found within the tendon of this muscle. Can you guess? The horse rider's muscle within the tendon of horse rider's muscle. Which is that muscle? That is adductor longus, muscle of the thigh. So people who are professional horse riders, they develop this sesamoid bone within the tendon of this muscle adductor longus. If you abduct the thighs, then in the groins, you can palpate for this tendon. It has a very small origin and a wide insertion on linea aspera. The origin is from the body of pubis anteriorly, right? So when you abduct the thighs, you can palpate this tendon in the groins. That is adductor longus tendon. And there you develop a sesamoid bones in people who are professional horse riders. Then there are some more sesamoid bones. Then is paired sesamoid bone. Where you find this? I'll tell you, it's found in the sole. So guess which muscle in the sole has sesamoid bones? This is found within the tendon of, because it's paired, so it is found between the two heads of flexor hallucis brevis. Within the two heads, it's a splitted muscle, right? So it has two heads, and between the two heads, what passes deep is the tendon of flexor hallucis longus. So the two sesamoids are actually present within the two heads of flexor hallucis brevis below to the ball of the greater toe. And what is that ball of the greater toe? That is the head of first metatarsal. So below to the head of first metatarsal, you find this paired sesamoid bone within the tendon of flexor hallucis brevis. And mind it, this will be more common in people who walk on toes, like the females who walk on high heels. So there are more chances of development of these sesamoid bones within the tendon of flexor hallucis brevis. Well, there are many other sites where people do develop this sesamoid bone, but at least these are common and these are important, so I have mentioned them here, right? Then the next question here is the three characteristic features of the large gut are. Now, I should say that this is not a precisely framed question, because if they are asking the gross features or the microscopic features, it's not clear. But they have asked 3 points. You have to mention 3 characteristics. So, if considering to be the gross anatomy of the large intestine, you can mention that there are hostrations. Hostrations are the dilatations, beaded form of dilatations in the large intestine. Then there is tinea coli. These are longitudinal muscular coat which are arranged at 3 different sides, at 60-degree angle along the circumference of this large intestine, tinea coli. And then appendices epiploicum. Now this appendices epiploicum is actually fat-filled bodies covered by peritoneum, mostly on the antimesenteric border or along to the tinea coli of this large intestine. I'm including the microscopic features also. Maybe if the teacher framing this question had an idea about the microscopic features, so you should know few important microscopic features also. One thing is that There is no villi in the mucosa. Unlike the small intestine, there will be leaf-like mucosal folds. Intestinal glands will be simple tubular or branch tubular, and abundance of goblet cells. Solitary lymphoid follicles distributed in the submucosa and lamina propria. Mucosal glands also. So that was about the fill in the blanks. That's completed. Now let's answer this 4 MCQs. Question number 1. Permanent kidney is derived from pronephros, mesonephros, metanephros, none. If you've been watching this video right from the beginning, then you must be knowing that I have already given this idea about pronephros, mesonephros and metanephros. So they are asking, is permanent kidney means the definitive kidney. Definitive kidney or the permanent kidney means it stays there till adulthood. Okay, let me explain you from the diagram now. So as I was telling you about the nephrogenic cord, which is named differently right from the cranial to caudal end in the cervical and upper thoracic levels, this is called pronephros. In the lower thoracic and lumbar levels, this is called mesonephros, and the same nephrogenic cord, when it descends down into the pelvis, it's called metanephros. Now this pronephros forms the kidney in human embryos in the very early weeks of development, and later on it descends down. There were being these mesonephric tubules being formed, right, that I told you was forming the nephrons for the embryonic kidney in the very early stages of the human embryo. But then the mesonephros takes up this development. Means the kidney start descending, the development of kidney actually is descending down in the nephrogenic cord from this mesoderm, from the pronephros, then mesonephros, then metanephros. Then the kidney starts developing from the mesoderm of the mesonephros. Later on, in the human fetus, the nephrons or the kidney, they start developing from the metanephros. So in the course of development of a human embryo, the development of nephrons keep descending down along the course of this nephrogenic cord. I hope you've understood. So definitive kidney to be formed from pronephros is still being seen to be functional in some fishes like cyclostomes. Then definitive kidney to be functional kidney has been seen to be developing from mesonephros is present in some amniotes, primitive vertebrates. While the definitive kidney, the functional kidney which persists and stays throughout life in human beings, is the one which is being developed from the metanephros. But in humans, during the embryonic life, the kidney also forms from pronephros, then from mesonephros, and the final one, which is going to stay lifelong, is being formed by metanephros. So this process of formation of kidney in human beings is called ontogeny repeats phylogeny. Means this shows our origin. It's like a biological representation that human beings have been evolved from the aquatic life and from the pre-vertebrates, then vertebrates, and then finally human being is being formed. So this process of development of kidney is a very good example of ontogeny repeats phylogeny. So your answer here is metanephros. In human beings, the definitive or the permanent kidney is formed by metanephros. So I hope you got the answer now. Metanephros is the answer. Next MCQ is arterial supply of uterine tube is through uterine artery, ovarian artery, both A and B or none. So easy type of question. I believe you all must have marked it correct. Of course, the uterine tubes will be receiving blood supply from both the sides. From the lateral sides, it will be perfused by the ovarian artery, and from the medial end, it will be perfused by the uterine artery. I'm drawing it here so it becomes easy for you at the same time. The uterus is, and here it is the ovaries. Uterine artery will reach here from the infundibular ligament, the infundibular portion, and will also supply the ovaries as well as the fallopian tubes. And don't forget, it also supplies the pelvic portion of the ureters also. While the uterine artery will ascend up, it's a tortuous artery and will also supply the medial portion of the fallopian tubes. So this is uterine artery and this is ovarian artery. One more thing, can you tell me uterine artery is a branch of? Yes, it's a branch of anterior division of the internal iliac artery. And ovarian artery, of course, it's a direct branch from the abdominal aorta, given out at the level of L2 vertebrae. So the answer here is both A and B is the answer, and that's the C choice. Next question is the third MCQ. Knee joint is which type of joint? Ball and socket variety, saddle variety, condylar and modified hinge, or ellipsoid and hinge? What will be your answer? I think most of you must have marked it correct. Although the most appropriate answer is still not among your options here. By the way, you can mark here is condylar and modified hinge, which needs to be a little bit corrected. One thing, it is not a condylar joint, rather it is a bicondylar joint. Remember this, the two condyles like medial femorotibial joint and lateral femorotibial joint, both are condylar joints. So we call that knee joint is a bicondylar joint. And I'll tell you that ACL and PCL, anterior and posterior cruciate ligaments, they also have a morphological significance of being the collateral ligaments. The posterior collateral ligament is supposed to be the medial collateral ligament of the lateral tibiofemoral joint. An anterior cruciate ligament is supposed to be the lateral collateral ligament of the medial tibiofemoral joint. So, remember this, I have told you that's not the important morphological significance that can again be an MCQ sometime in your next exams. And writing here as modified hinge is not required actually. First thing, it should not be written as and. When you are writing and, you are actually not classifying it as a single joint. You are mentioning two other different things. It should be or. How can a joint be classified into two categories of the same varieties of the synovial joint? And there is no such modification of hinge. Hinge means completely the movements are permissible only in a single plane. Flexion, extension only. So, if you are written as modified hinge means what? You are trying to include the locking, unlocking means medial and lateral rotation, right? If you included this rotatory movements, then first of all, it is out from the category of the hinge joints. So I think there was no need of writing it as modified hinge here. It's simply a bicondylar joint. Now the last MCQ here is spermatic cord contains vas deferens, pampaniform plexus of veins, testicular artery, all. Super easy question. You all must have got it correct. So the answer is all. But it is still not complete. You should know all the contents of the spermatic cord. So just stay focused. Contents of spermatic cord. This is a super important question. This is not only being asked in your MCQ, rather it is also very commonly asked as a short answer question. So first of all, you should know that the spermatic cord has different layers, right? Because it's like a continuation of the invagination of fascia transversalis to the deep inguinal ring, right? So the fascia transversalis is going to be the innermost ring, like this. This is internal cremasteric fascia. Then outside to that, within the canal, you will find that those fibers from the internal oblique, transversus dominus, they contribute to form a fibromuscular loop which descends down surrounding this, and that is placed here outside to this internal cremasteric fascia. And now this is called the cremasteric fascia because not only the muscle fibers, it also has connective tissue in between. So this is the cremasteric fascia here, formed by internal oblique and transversus abdominis. Now when it reaches to the superficial inguinal ring, there was this ring being formed by the aponeurosis of external oblique. So this aponeurosis of external oblique will invest this continuation of this spermatic cord from outside, and that will form this layer from outside, and that is called the external cremasteric fascia. There's one thing which was also coming inside the inguinal canal through the deep inguinal ring, and that was the fold of peritoneum, and which continues down along to the length of this spermatic cord. Later on it gets degenerated, right? And that is called the processus vaginalis, which forms a covering around the testis in the form of tunica vaginalis. But most of this degenerates. So you can form somewhere here like this as a remnant of processus vaginalis, just to make you learn the contents. I am telling you all the little bit important facts. So one important thing which you find that passes through the spermatic cord is the ductus deferens, also called the vas deferens, thick muscular coating around to this. And this vas deferens will of course be accompanied by an artery to ductus deferens. Well, there's one more artery within this, and that is a bigger artery, and that's the gonadal artery, also called the testicular artery. There's one more artery which is actually supplying this muscle coat, this cremasteric fascia. So this artery you can place it here, like within the cremasteric fascia, because it's for this muscular loop. So this is cremasteric artery or artery to cremaster. Well, this also will be accompanied by a vein here, but in this spermatic cord you don't have any testicular vein, rather you have a plexus of veins. This is called pampaniform plexus of veins. This you find around to the vas deferens. You also find around to the testicular artery, and even spreaded around like this. This is all a plexus. In case of varicocele of this pampaniform plexus, it is felt as a bag. The scrotum is felt as a bag of worms. Many a times it has also been asked, like, why there is more often this hydrocele, or let's say this dilatation of the pampaniform plexus of the veins, rather. This is more importantly asked, like this varicocele being formed. Why is it more common on the left side? Simple is that that the venous drainage from the testis, from the right side, the testicular vein drains into the inferior vena cava directly, but on the left side it drains into the left renal vein. So it doesn't causes the spine to reach on the right side to drain into the IVC. So it takes a shorter course, and it's being drained at 90 degrees to the renal vein. So there are more chances of collection of blood here in the left side. Then talking about the nerves, one nerve, this genitofemoral nerve, the genital branch of genitofemoral nerve, this you will find within the cremastic fascia, right? Because it's coming from, between these muscle layers, internal oblique, transverse abdominis. From there it is reaching here. So it will be running within this cremastic fascia and it is supplying the muscle cremaster. This is called the genital branch of genitofemoral nerve, which is also called nerve to cremaster here in this. There was one more nerve which was a content of the inguinal canal, but as this nerve crosses the superficial inguinal ring, it will pierce the external cremastic fascia, that is the aponeurosis of external oblique, and will come to lie outside the spermatic cord. Now this is ilioinguinal nerve. This is a content of inguinal canal in both male and females. Then you also find this sympathetic plexus or autonomic plexus of nerves surrounding to this arterioductus deferens, because it's coming from the pelvis. Don't forget to mention about the lymphatics, because within the testis these are the lymphatics surrounding to the ductus deferens. This also is one of the contents of the spermatic cord. Finally, I did not purposely label this diagram so that it will be a means of revision for you all. Now fast keep telling me, what structure is this? External cremastic fascia, which is a derivative of aponeurosis of external oblique abdominis. Then, what is the brown color thing in between? This is cremastic fascia, which is continuation of fibers of transversus abdominis muscle and internal oblique muscle. The pink color layer, the innermost layer, this is internal cremastic fascia, which is a continuation of fascia transversalis. There was one more structure which was running within the spermatic cord right from the deep inguinal ring, and this was processus vaginalis, which is a derivative of parietal peritoneum. Then what was this thick muscular tubular structure? This was vas deferens or ductus deferens. Surrounding to this was an artery, and this is called artery to ductus deferens. It's a branch of artery to ductus is a branch of superior vesicular artery. Superior vesicular artery. And that's why it's surrounded by this autonomic nerve plexus, right from this hypogastric plexus. So surrounding to this artery is the autonomic plexus, autonomic nerve plexus. What was this artery? This is the testicular artery. The testicular artery is a branch of abdominal aorta. What are these blue colored things? This is the pampaniform plexus of veins, which will form, eventually join to form the testicular vein on both the sides. And I've told you about the drainage of this testicular vein on both the sides. Then there were these lymphatics also. Within the cremastic fascia, this was genital branch of genitofemoral nerve supplying cremastic fascia. And what was this? This is artery to cremaster. Now, artery to cremaster, this is a branch of, remember, it's a branch of inferior epigastric artery. Then this blue color vein, of course, will be veined from cremaster, cremastic fascia. And what lies outside to the external cremastic fascia is the ilioinguinal nerve. Ilioinguinal nerve is from the anterior division, the anterior primary rami of L1 spinal segment, and genital branch of genitofemoral nerve is L1, L2. Ventral division from the anterior primary rami of L1, L2. So enough of it I have covered up. This might help you and help you solve a number of questions. So finally it is done with the MCQs. Now this is a clinical question. A 65-year-old man who suffered myocardial infarction was admitted for coronary bypass surgery. Surgeon used patient's long saphenous vein and reversed it for the surgery. What is myocardial infarction and coronary artery bypass surgery? Simply, there's lack of perfusion of the myocardium, the muscles of the heart, because of diminished or loss of blood supply to the muscles of the heart. So that is myocardial infarction. And coronary artery bypass surgery is you have to bypass that portion of the coronary vessel which has already been blocked. So to bypass that blockage, you can compensate it either with a venous graft, as the surgeon has already planned in this question. Another one is using the left-sided internal thoracic artery, or internal mammary artery. That also is a direct graft to bypass that blockage of the coronary artery. So that is called CABG, coronary artery bypass graft. Why was long saphenous vein used and reversed for the surgery? Long saphenous vein, basically it's presumed that the venous drainage of the lower limb is most of is through the deep veins. So that can be used, long saphenous, but because it's a valvular vessel, right? And coronary arteries don't have valves. So you can reverse. That's why it said that he reversed it for surgery. So reversing is we are trying to move the valvular thing, the endothelium having the walls, that has to be reversed, and for the tunica adventitia, which is the outer layer, that will be now inside. So that is to remove the walls inside. This method, what they mentioned, is what was used very earlier. Now this has been replaced by CABG, coronary artery bypass graft, and that is replaced by internal mammary artery EMA graft. But remember that it is not a very successful thing, because the arterial pressure is high compared intra-arterial pressure. The walls of the artery are meant to sustain a greater pressure, unlike the walls of the veins. So that's why arterial graft is preferred. Which other blood vessel used for internal for coronary artery bypass grafting? Already I have told you that is internal mammary artery of the left side. Write short notes on any 5. Descent of the testis, hepatorenal pouch. This is also called as hepatorenal pouch of Morrison. Inguinal ligament, folding of aponeurosis of external oblique, bronchopulmonary segments, Meckel's diverticulum. Remember the formula of 2 by 2 by 2. What was this? 2 inches in length, 2 feet proximal to the ileocecal junction, and present in 2% of the population. Trigone of the bladder, I just described it in one of the descriptions regarding those fill in the blanks or MCQ somewhere before. Being derived from the covering of this trigone being developed from the mesonephric ducts. Explain briefly any 3 supports of uterus, femoral canal, locking and unlocking at the knee joint. So easy. Locking is by which muscle? Yes, vastus medialis. This is vastus medialis, locking muscle. Unlocking is by popliteus. Then major openings in the diaphragm, that it's so easy. Esophageal, aortic, and vena caval opening, central tendon opening, T8 vena caval, T10 esophageal, T12 aortic opening, and the rest of the structures passing, you'll have to describe them all. This is section B again. This is of 50 marks. Question 6. Describe portal vein under its formation, course, tributaries, sites of portocaval anastomosis, and its clinical importance. Is so super important question, a long question of 20 marks. Always prepare this question before preparing for your exams. Explain why any 5. Why do inhaled foreign particle body tend to pass into the right lobe of the lung? I believe I described you with about the trachea and the principal bronchus, along with the description I made on this fill in the blank somewhere before. And Obviously, this trachea is slightly tilted to the right. The right principal bronchus is shorter, wider, and more alignment with the trachea, and that's why more chances of inhale particle to reach to the right lobes. And if you talk about the BPS, which is more common, then it is the apical portion of the lower lobe. That's the sixth bronchopulmonary segment. Why the soleus muscle is known as a peripheral heart? Of course, it has a lot of venous sinusoids within it, which communicate with the perforator veins to the deep veins. So, contraction of soleus helps to pump the blood against the gravity. Why femoral hernia is more common in females? Wider pelvis and the wider canal in females, and shorter blood vessels, and of course, being a gravidarum, in pregnancy, there is more of compression of the structures in the inguinal region. So these are the few reasons why femoral hernia is common in females. Why the pain of appendicitis felt in them like a simple is, that is the T10 dermatome, and T10 spinal segment provides the sympathetic autonomic innervation to the appendix. So the pain is referred to the umbilicus T10. Remember, spinal segment we're talking about. Why varicocele are more common in the left side of the so important. I just described it there in one of those descriptions above. Contents of the spermatic cord. There I described this. Varicocele are more common on the left side of the body because the left testicular vein drains to the left renal vein at a 90 degrees. So there's less amount of pressure for the venous drainage from this left testicular vein. So there are chances of collection of blood in the left testicular vein for the retrograde collection of blood, and that leads to the varicocele on the left side. Why the pain on the hip joint is felt at the knee? So simple. Hip joint and knee joint, they have common nerve supply, and remember that it is this femoral nerve through this nerve to rectus femoris supplies hip joint, and femoral nerve through nerve to vastus lateralis, vastus medialis, and vastus intermedius that supplies the knee joint. Then obturator nerve also supplies the hip joint through its anterior division, and obturator nerve supplies knee joint through its posterior division. So because of the common nerve supply, the pain from one joint is referred to the other joint. So why the pain is from hip joint is felt at the knee joint? You can also reverse it, that the pain from the knee joint can also be referred to the hip joint as well. Explain briefly any four lobes of the prostate. Super important. This is developmentally also important. Then deep inguinal ring is also important. Rotation of the midgut is one of the important questions of the embryology portion. Microanatomy of the appendix. Don't forget to mention those lymph nodules here. Remember, microanatomy of appendix. Appendix is also called as the abdominal tonsil. So don't forget to mention those lymphoid aggregates there. Cross section of thorax at the level of T4 vertebrae is super important. This is the lower limit of the superior mediastinum. So it is done.